This is everything you want to know about COVID and the COVID vaccine. My name is Dr. Crowder, also known as Dr. V. I'm an emergency medicine physician. I've been practicing for 30 years. I have a website, AskDrV.us, that has all the documents and research, and it also has invite there. So if you want to actually invite somebody to this, you can send them your link, or you can send them to that website. And then I'm also on Twitter. All of these presentations, not including the Q&A, are recorded and then uploaded, so you can always go back and reference them. And they're always dated because information changes quickly. So this is January 19th, 2020. Let's get going. All right, the structure is a slide presentation that's about 15 to 20 minutes, a little bit more than 10 to 15 today, because there's so much new information, and then followed by Q&A. During the presentation, everyone is in listen mode. You can begin while you're in the presentation to load up your questions into the Q&A or into the chat. So sometimes you have questions that come to you, you don't want to have to remember them. Go ahead and go to the chat icon or the Q&A icon and put those questions on in there. All right. The intention is for webinar participants to stay informed about COVID-19 that will help them and their families stay safe. The structure is that you're motivated to create or improve an action plan for yourself and your family. Or you may be motivated to create or improve an action plan for a broader community. Maybe it's a church, homeowners association, school, business, etc. So let's look at where we're at. 96 million cases of COVID globally. The United States is 4% of the world's population, but we are 25% of the global cases of COVID-19. Similarly, for the deaths, there's 2 million deaths globally, and we are also 25% of that as well. Just recently topping 400,000 deaths. That is more people than we lost in World War II. According to the Veterans Affairs Association, we lost 405,000 people in World War II. So we have now lost more people to COVID than World War II. Again, if you look at us compared to other countries, we don't do so well. So this just takes a look at UK, Germany, Canada, Mexico, and Japan. COVID seems to be everywhere, including the San Diego Zoo. The 2 gorillas tested positive. The first known cases amongst the great apes, they were asymptomatic and they're doing fine. Vaccines. We've distributed 31 million vaccines, but we've only administered about 12 million. So there's still, another 20 million or so vaccines to give out. And then, then from there, the healthcare system really needs to purchase more for health and human services, etc. So there's been a lot about the surge and the need for healthcare and what happens when you have a collapsing healthcare system. So I want to go over some of the things that happen, because this is really important should a family member get ill. So you actually know how to advocate on their behalf and what's normal and what's not normal. So you may see unusual spaces used for hospital beds. With LA County Hospital, they're using the gift shop and the chapel. Facilities can be running out of PPE, oxygen, and most importantly, staff. There may be ambulance diversions, or you may call 911 and 911 says, we're not going to transport you because you're not sick enough. You are able to get in your car and still go to the emergency department. Just because the ambulance isn't going to take you doesn't mean you can't go there. Now, let's take a look at some other things that happen. When you start getting the ERs, the hospitals that are full, then what happens is you have more patients holding in the emergency department and not able to get upstairs. I know in California, they've lifted the criteria so EMS can begin pronouncing patients in the field prior to transport. And you also have ethics boards that are being formed in the hospital, setting standards on when to withdraw care. So normally the withdrawal of care is up to the family members with the DNR, a do not resuscitate order, but you will see hospital ethics boards actually set those standards, whether or not family agrees or not. I talked a lot about the fact that I'm not flying. This is just a chart that I really love, because at the end of the day now, only Delta Airlines is actually not selling the middle seat. So only Delta Airlines is holding the middle seat. They said that they're going to hold it until March. All the other airlines are selling the middle seat, so now you can actually get on a flight that's really quite packed. And some airlines are not even cleaning the plane prior to every flight. So there's a lot to be desired in U.S. airline travel. Now, the United States did actually put together this thing that required all international air travelers to show proof of negative virus tests before leaving. That is actually going to take place, that's going to actually take effect on January 26th. Now, what is interesting is that Canada did that about a month ago. They actually did it on January 7th. So not a month ago, maybe about 2 weeks ago. So Canada has a contact tracing system for all of its flights. Since January 7th, they have had 70 flights that have carried COVID positive patients, despite actually having this in place that you have to actually have a COVID negative test. So this just shows that there were 2 flights, international flights, and within hours, Air Transat informed everyone on the flight that they were potentially exposed to COVID-19 and recommended that all of them get tested. In the US, we are not doing this. So I wanted to actually show an example of it actually being done in Canada. So Canada has actually done this 70 times since January 7th, where they've notified people. In this particular flight, there was more than one person that was COVID positive on the plane. And given where they were seated, they recommended that everyone on the plane on both flights actually get tested. As we know, respect COVID-19 is highly contagious. Only 45 seconds of exposure is needed to infect others, and about 60 to 80% of the people who come in contact with COVID-19 will actually get it. As we've talked about, it's both droplet and airborne. The droplets only go about less than 3 feet from you, but the airborne particles actually are smaller and travel much, much further. So it kind of looks like this. If somebody's COVID positive, the droplets are in red, and gray is the airborne. COVID-19 testing, if you want to get testing, and how do you know if you're a positive or not? PCR test, antigen test, or CAT scan. PCR test is a gold standard. That's the swab that is very, very uncomfortable and is actually put up your nose, is most accurate 8 days after exposure. But it can be inaccurate if it's done too soon or done too late. The antigen test is the rapid test. That test is normally, they just swab the side of your mouth. The problem is it tells you that it's negative 30% of the time when you actually do have COVID-19. We say that someone's negative if they have 2 tests back to back that are negative. CAT scans. This is another way you can actually tell. It gives you a ground glass opacification in both lower lungs. And that is the pathognomonic or the best diagnosis for COVID-19. The pooches can smell COVID-19. So the dogs would be a very good way to screen in schools and things like that. They actually are more sensitive than our testing. There's also a test that's FDA approved on Amazon. You do have to send this test into the lab. This is not a test where you can actually process it in your home and be told if you're positive or negative in your home. All right, we talked about the clusters of symptoms. Cluster 1, 2, and 3 are more likely to be self-limited type of disease, where you get flu-like without a fever, flu-like with a fever, or you get vomiting and diarrhea. All of them are preceded by loss of smell or loss of taste or loss of appetite. Cluster 4, 5, and 6 are more likely to require hospitalization. These are fatigue, confusion, or a mixture of abdominal and respiratory symptoms. This just shows what sort of symptoms occur when. About 78% of the time people have a fever, 22% of the time they do not. So the fact that someone doesn't have a fever doesn't necessarily mean that they don't have COVID. If you look at coughing, coughing only occurs 57% of the time. So as you can see, COVID-19 can look look very, very different in different people. Now, COVID-19 versus the flu. Many, many more people get the flu, but the flu is not as deadly. So in any particular year, you can have 10, 20, 30 million people get the flu, but we'll rarely have more than 20 or 30 people dead. 60, 70, 80 is like a really, really bad flu year, which there was one of maybe about 8 years ago. So 60 or 70, 80,000 people would be a lot. We are now, I'm sorry, this slide, we didn't update this slide. We are now at 408,000. So, and this is not a year yet. So as you can see, we are, COVID is, almost 5 times more deadly than the flu. COVID-19 is also distinct in that it's shut down all elective procedures. 100% of the patients are in the ICU, and many hospitals have COVID. It is a multi-system disease, not a respiratory disease. So it causes renal failure, myositis, strokes, blood clots. People require double lung transplants after COVID-19, and some people are in the ICU and require ECMO, which we'll talk about a little bit later. These are not things that you see happen when someone has the flu. We talk a little bit about what to do if you're positive. Everyone should have zinc, vitamin D3, and a pulse ox machine at a minimum in your home. That way, just in case you do wind up getting sick, you have everything that you need in your house. You want the pulse ox, which is the SpO2, to be over 95%. It's also best to have a room that's only used by you, cell phone, where you call 911, not a family member. Leave food at your door. And then keep your windows open and have a HEPA filter if you can. All right, how to advocate for somebody that is hospitalized, a family member or a friend. And I apologize for the typos. We've done 2 webinars back to back and a COVID memorial today. So we were racing with these slides. So I apologize if you see minor typos. But this is how to advocate for somebody who is hospitalized with COVID-19. 1, you want to have one family member that is appointed to actually be the point of contact with the physicians or the nursing staff. That one person needs to clearly know who is the nurse, which will change from day to day, who is the attending doctor. The word attending is very, very important because there are residents, sometimes there are interns, sometimes there's even people who are in their fellowship. The attending doctor is the physician that is actually responsible for the person's care. Also, who are the specialists that have been consulted? So you don't want to know, they consulted a cardiologist. You want to know they consulted a cardiologist and his name is Dr. Sunan, whatever it may happen to be, right? And so you want to know the specialty as well as the name. Now, some people are concerned about whether or not they're calling too much to check on the person. So the nurses are actually trained to take these calls. This is part of their job. So you don't necessarily want to be concerned about, oh, am I calling too much? But what I would do is I would set a time to call. You could say, I'm going to call every morning at 10 a.m., right? And they will make sure they have all the information, and that way they're prepared for the call. I always tell people, remind people that in some hospitals, shift change is usually at 7 a.m. Sometimes it's at 8 a.m. So you don't want to do a 7 a.m. or 8 a.m. call. Make sure the medical staff is aware of what this patient looked like and what their life was like prior to becoming sick. In a hospital bed, people are often not able to walk. They're laying there, they may be losing weight, they may look older or more debilitated than they really are. So it's very important to remind your hospital staff, was this person working? Were they driving? Were they living without assistance? Were they exercising, running, playing tennis? What was their normal status? Also, what were their wishes? Did they want to be put on a ventilator? Did they want to be resuscitated? Did they want to be put on ECMO? What were their wishes around how advanced they wanted their care? Do they have a DNR? Also, is there something else that they do not want done for religious reasons? There's some people who don't want blood transfusions because they're Jehovah's Witnesses. So any wishes of the patient that you want to actually, you want them to abide by should be communicated. Now, I tell people, be aware of the 30-day push. The 30-day push is just this. Most insurance companies do not pay for you to be in the hospital past 30 days, or the reimbursement goes down significantly. So you will see around day 20 to 30, okay, well, maybe we need to put a tracheostomy in him and move him to a vent-dependent nursing home. You want to make sure that your primary care doctor and any specialist is actually that your family member is stable enough to move, and that there is an agreement to do this. What often happens is patients get discharged to kind of meet the 30-day push. They go off to a rehab center or a nursing home, and they bounce back to the hospital because they weren't really ready to go. Any physical, that's physical, not physician. Sorry about that. Physical or mental rehabilitation, you want to make sure you're getting enough. You want to make sure you know how to replicate it at home. Should it be 2 days a week, 3 days a week, 4 days a week, or 5 days a week? At discharge, you want to be clear, what are the home health services that are being provided? Often people will be told, well, I'm going to have home health services 3 days a week. Okay, well, when are they starting? Oh, they're not starting for a month. That's significant. You need to know how to actually fill that gap, right? Also, you want to look at what sort of equipment is needed. Do you need bedside commode, a bed that elevates, a wheelchair, walker? You want to make sure that you have everything you need before you take your family member home. Now, we talked a little bit about COVID treatment plan. And outside of oxygen, vitamin D and zinc are really, really important things to make sure that you're taking now. You want to take this preventatively before you actually get anything. Famotidine is Pepcid AC. We'll talk about that. Steroids, remdesivir, which is really not given as much anymore. And I really want to talk about the antibody cocktails. I had a family member this week who became COVID positive and didn't know to take the antibody cocktail. So I want to actually talk about that, and ECMO. So famotidine is Pepcid AC. It blocks histamine release, and it lowers hospital deaths and combined death and intubation rates. This is something that you can have at home, and then that way, if something happens, you have it. Steroids are given in the hospital, and they also lower the death rate. You may or may not see the use of remdesivir. It really has questionable benefits. Some places are really getting away from using it. The antibody cocktails, these are really, really important. I know a lot of people are talking about the vaccine. I want to talk about the antibody cocktails because there are people that are still getting COVID positive. And the antibody cocktails are by Regeneron or Eli Lilly. They have two types of antibodies. One that is a human that is recovered from COVID-19, plus antibodies from a mouse that's engineered to have a human-like immune system. These antibodies lower the likelihood of hospitalization by 70%. If we were using these antibodies, we would be avoiding a lot of what we're seeing on TV. And a lot of patients don't know to use them. Sometimes they get positive, people get positive and they think, well, I just need to stick it out at home. No, it's very, very important. And they have to be administered within 10 days or they are of no use. So that's really, really important. Now, I got asked a couple of questions before about ivermectin. So there's several studies associated with ivermectin. This is one that actually looked at this use in hospitalized patients. And basically, it showed a lower mortality rate in hospitalized patients. This is from a magazine called Chest. Now, a lot of these are studies that we call observational studies. So basically what they're doing is they're trying it and then comparing it to historicals. This is just a little bit about Eli Lilly's antibody treatment. It was approved back in November. So most facilities should actually have it and have infusion centers set up. So You need to find an infusion center. And if you look, this is a screening tool for one. What's important is that anybody that is over 12 years old qualifies for antibodies if they are overweight, which is a BMI over 35. That's a woman that's about 5'6", 5'7", and 170 pounds, or a man that is maybe 6 foot tall and about 200 pounds. You qualify for antibodies. Kidney disease, diabetes, any sort of immunosuppressive treatment, you qualify for antibodies. The other way to qualify is if you're over 65 years old. And again, this has to be done before 10 days. So it's really, really important. If somebody in your family or your life becomes positive, I would ask them, do you qualify for antibodies? You need to go get screened and see if you qualify for antibodies. We talked a little bit about ECMO, just so that everybody knows what it is. It's basically a heart and lung machine, but it stands for extracorporeal membrane oxygenation. Basically takes the blood out of your system and oxygenates it outside and then sends it back in. This is a very, very, very critical intensive care machine. It normally, there may be only 5 or 6 of them at a major hospital. So these are reserved for people that we cannot ventilate, that are in the ICU, that are struggling, that are young. These are a couple of other treatment protocols that people had asked about. One is called Math Plus. This just shows you everything that's involved with Math Plus: steroids, vitamin C, thiamine, heparin, which is a blood thinner, statin, zinc, vitamin D3. All of these are going to have zinc, vitamin D3, and Pepsid AC. Melatonin and magnesium. This was used on 300 patients, and it lowered the mortality rate by 75%. This is one that they're currently studying now with ivermectin. Again, it's ivermectin, zinc, vitamin D3, always there, aspirin, vitamin C, and they're also using this thing called quercetin. And this is a plant-based flavonoid, which is basically what you can find in green tea or in capers. And then also melatonin. So I'm seeing melatonin as another thing that's coming up repeatedly in some of these different protocols. We don't have the results yet on this particular one, but this is a study that is currently going on with ivermectin. We talked about the fact that you could catch COVID twice. The lady on the left is 102. She caught it twice and survived. The teenager on the right was 18 years old, and he caught it twice and passed. They did a study in UK and found that your immunity basically begins to wane after 3 months, and after 5 months, you're basically at risk for catching another infection. All right, quickly we'll move on to the vaccines. This just shows how COVID gets into your body and replicates. The virus is inside the cell. The outside is a fatty layer. It connects with a receptor protein, gets into your cells. Then the RNA turns it on and tells it copy, 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 copy. And it copies not only the virus, but it copies the spike protein, it copies the fatty cell, it copies everything, and it sends the copy out to go infect another cell. And so this happens over and over and over and over again. So messenger RNA, there's a lot of different types of RNA, but this is the thing that transfers genetic information. It is important that messenger RNA is not as new as people are making it seem like it is. Messenger RNA is new for vaccines, but we have used messenger RNA before in oncology treatments. So the technology itself has been used before. The Moderna and Pfizer vaccine actually both use the messenger RNA, and basically they tell your body to make a part of the spike protein of the COVID-19, and then your body makes it and then recognizes it and kills it. So when your body sees COVID-19 in the real community, it's actually ready. You're going to hear more and more about Johnson & Johnson. Johnson & Johnson is probably going to submit for emergency authorization in the next 2 to 3 weeks. This vaccine is a one-shot vaccine. It is a viral vector approach, and basically what it does is it combines COVID-19 with an adenovirus, which is a virus for the common cold. It teaches the body that that combination is as harmless and generates antibodies for that COVID-19 that's attached to that adenovirus. All right, so 2 doses are needed for both Pfizer and Moderna. They're both about equally effective, 92% effective, 95% effective. Both of them have similar side effects. One has to be stored in liquid nitrogen, the Pfizer, and the Moderna has to be stored at 20 degrees. People have asked me, which one am I going to get? I'm going to get whichever one they give me when I go to my appointment. So I had an appointment last week, and I actually I had the wrong address to get there, and then when I got the right address, they were done giving them. So that would have been the Pfizer. And then I made an appointment in DC, which is giving out Pfizer. But I also found a clinic in Pennsylvania that said they would give it to me this coming Saturday, which was faster than DC, and they're going to give me Moderna. So it looks like I'm going to get Moderna, even though I've had 2 appointments for Pfizer. I tell people I really wouldn't worry about it. As long as you're getting Pfizer or Moderna, you're probably fine. I will say this is that if you're older, if you're over 65, it does look like the Pfizer vaccine works better in people that are over 65. All right, there was this whole framework for how to give out the vaccine. We're not using that anymore. Now, basically, anybody over 65 and anybody who's a healthcare worker right now is the phase in which we're going through. You may still need to wear a mask because we're not sure how much you're able to transmit the virus. So the data on transmission has not been fully studied. Interestingly, Israel just came out and said that they have the data on transmission for Pfizer, and they told Pfizer they would release the data for them to them in lieu of some additional vaccines. So this is just what we talked about earlier. All righty. So a lot of essential workers, they're telling them, you may need to wear a mask at home so that you don't actually infect each other, because you are, even once you're vaccinated, able to possibly, we don't know, transfer. All right. This is basically the schedule of the next upcoming Johnson & Johnson. I think you'll see first. AstraZeneca will also be ending right around the end of January, beginning of February. Novavax has actually initiated phase 3. They actually have a site. They are doing a study protocol at Howard University in Washington, D.C. So I know that that is a Novavax site. All right, just a little bit more about Johnson & Johnson. I think that what we're going to see with Johnson & Johnson is I think you're going to see results that are probably not quite as good as Pfizer and Moderna, but fairly good given that it's one shot. Now, a lot of people have been asking me about the mutations, so I've added these slides as well. So now, I just want to be clear that we do not do genomic testing and surveillance like we should, just like we don't do contract tracing like we should. So because of that, we really don't know how much of any mutation is in the United States, because we are not doing the work. Our system is so overwhelmed, we're not able to actually do that particular work right now. But let's talk about what they are. So I've put the real name of the mutation on the left. You will hear about it in the news, and they will refer to it by where it's from. So you'll hear them say the UK variant. And that is now over in 50 countries. It is a small physical alteration to the spike protein. We believe it'll be the predominant strain by March in the United States. What is important about it is it spreads 70% more efficiently. So if before you could catch COVID in 45 seconds, now it might be 15. People are having higher viral loads. Young people are getting sick, and people in general are getting sicker. So if you have not upgraded your mask, please, please, please upgrade your mask to a KN95, right? And do not go to a restaurant or any sort of indoor place. Now, the other variant is the South African variant. That has a large amount of physical alterations to the spike protein and has the highest likelihood of really escaping our vaccination. We don't know, we don't have the information on it yet. It is now the most common strain in South Africa and Zambia, and it seems to be very dangerous also to children. The P1 and P2 is a Brazilian variant. We've seen increased transmission rate with this and also reinfections with people that already had COVID-19. Lastly, the problems in California and why California seems to be having such a surge. California seems to have its own variant, which is called L425R, where again, because we actually don't do the genetic surveillance, it's been detected, but there's some people that are wondering, is that why California is having such a problem? So again, there's all of these mutations. We don't necessarily know what it's going to mean for the vaccine. One thing that is actually really important that I tell people is just because the virus is mutating, you have to remember your body is also adjusting. So neither your body and your immune system, nor is the virus static. Last week, a World Health Organization team arrived in Wuhan. This is going to be very, very interesting. This was and the goal was to see where did this virus and how did this virus actually start. So they hit the ground last week. It'll be interesting what we find in the next month or two. The World Health Organization chief, General Tedros, basically told people, we need to prepare and we need to have a way as a group worldwide that we can come together and prepare for pandemics, because this one will not be our last one. How do you get your vaccine? If you're over 65 or you work in a health department, in a healthcare field, you work in a healthcare field, probably your employer is going to vaccinate you. But if they don't, you can search your county public health department, search COVID vaccine, and they'll give you instructions to actually schedule your vaccinations. If it says no appointments, you can set up text message or email alerts. I'd highly recommend that you do that. I noticed that in Washington, D.C., they had 1,400 appointments that became available Monday at 9 a.m. They were completely full by Monday morning at 9:30. So in 30 minutes, 1,400 appointments were gone. So you really want to get on an email or a text message alert for vaccinations. All righty.